Hello, I'm Jota Lourida. I'm an infectious diseases and HIV physician from Athens, Greece, and I'm going to be talking about comorbidity screening and prevention for women after menopause. These are my conflicts of interest, and I'm going to start by some numbers. We know there are about 40 million people living with HIV, and 53% of those are women. And globally, 44% of all new HIV infections were among women. People with HIV are aging because we are getting better at treating them, but by 2030, approximately 1 in 3 people with HIV around the globe will be over 50 years of age. And today in Europe, we are facing a mature epidemic because the new diagnoses in the over 50s stand at double the rate of those in the younger age group. This has direct results and effects in the healthcare systems around the globe. And we also need to remember that women of all ages and people over 50 have high percentages of late presentation among the newly diagnosed in Europe, and that adds more challenges to the HIV care of these populations. There is contradicting evidence whether HIV can cause earlier menopause. There are data from different parts of the world supporting this and reporting menopause 2 years earlier or up to 27% early menopause in this population. But the argument here is whether this is related directly to HIV or rather to other factors such as substance use, sociodemographic factors, ART, hepatitis, immune status. Some data suggest menopause symptoms may be more pronounced in women with HIV, but there is no evidence of changing hormone levels that they affect CD4 count or ART effectiveness. The European guidelines have an extensive and detailed coverage on comorbidity screening, diagnosis, and management. And all these marked in red are aspects of a woman's health that can be affected sometimes deeply during perimenopause and menopause. So the guidelines give us tools and checklists to assess cardiovascular, bone health, cognitive status, frailty, other issues and other comorbidities, other topics very important such as sexual health. I'm not going to go through all the lists of proposed diagnostic and therapeutic algorithms. These are essentially the same for all people living with HIV. I will try to focus on a few points that are most deeply related to menopause in women living with HIV. So we have robust data that women with HIV face a higher comorbidity burden pre and especially post-menopause compared to women without HIV. This recent study is a good example. The two populations were compared. Median age 48, over half obese, 65% Black, and menopausal status, age, and HIV were independently associated with higher comorbidity burden. This higher burden is explained by a number of reasons. First of all, the well-known HIV-induced chronic inflammation, but also some effects that ART may have on body weight, composition, cardiovascular risk, bone and mental health, to name a few. We know cardiovascular risk, osteoporosis, are more prominent, more often found in people with HIV. And we also know the struggles women with HIV face regarding mental health sometimes, and they face issues that had to do with lifestyle, HIV itself, but also the stigma surrounding the diagnosis and social factors. And I cannot stress this enough when we are talking about menopause. Most people think we're talking about a transition short period, but this is not the case. Menopause can affect a woman's health and life from very early, from the first signs of perimenopause until the end of her life. So the issue here is that we need to realize it has a profound impact. So we are going to take a quick look at the most important comorbidities, starting by cardiovascular risk. And we know that this is the first cause of death in women, and it's underestimated by both women and medical professionals. There are differences. Non-occlusive and microvascular disease is more common in women, and early menopause is an independent cardiovascular risk factor. American Heart Association has given us the essential 8, the most important topics and pillars that we need to discuss in order to assess cardiovascular risk and prevent disease. Diet, physical activity, nicotine exposure, sleep health, this is a new one, behavioral components, and the classic risk factors, obesity, lipids, hypertension, glucose. All these factors are affected during menopause, and all these factors, and we know this well, caring for women with HIV, are topics where women with HIV also face challenges to a great percentage. Women with HIV have additional risks imposed by their HIV status or treatment, as mentioned before. And although specific ART categories may have been linked to increased cardiovascular risk or dyslipidemia, overall, we need to stress that early ART initiation reduces cardiovascular disease. We've seen this clearly in the SMART study, and also ART improves immune activation and arterial inflammation. There are lots of relevant data. This is an example of a recent study demonstrating that women with HIV have higher incidence of lipid disorders and metabolic syndrome compared to matched women without HIV. This type of study focusing on women is very important because women with HIV are historically underrepresented in studies, and it is really important to have clear data. And this is one of the many, many reasons the REPRIEVE study is so important. 31% of the study population were women 40 to 75 years old on stable ART, low to moderate cardiovascular risk, and statin use was beneficial in this subpopulation also. So the REPRIEVE study had an impact on our clinical practice. The US guidelines followed the study's framework and recommend statin initiation of at least moderate activity, moderate intensity, based on the same score used in the study, whereas the European guidelines propose the use of a European score, the score 2, and advise to consider moderate statin therapy after discussion about pros and cons. So in both cases, this is not a practice recommended to the general population, but a practice unique to people living with HIV. What is the effect of menopause hormone therapy on cardiovascular risk? As extrapolation from what we know from the general population may be beneficial, we have some data specific on women living with HIV, like those from this study, demonstrating beneficial hormone therapy effects on subclinical atheromatosis. Now, a few words on bone health. We know menopause is one of the major osteoporosis drivers, and we also know that we need to actively screen, as osteoporosis does not present with symptoms until it's too late. Besides menopause, there is an extended list of all classic osteoporosis risk factors, some very often seen in women living with HIV, and also a list of medical conditions that cause secondary osteoporosis. We are asked by the guidelines to go through these lists, but also to think about HIV and ART specific risk factors. We know that ART initiation is related with a loss of bone mineral density, especially the first year, and that there are antiretrovirals that have a greater effect on bone mineral density, such as classic tenofovir. And it seems that TAF is associated with less bone loss than TDF. So after assessing all these factors, we need to screen with a DEXA scan and do a FRAX score risk prediction. According to the results, we either treat or manage and or repeat the scan every 3 to 5 years for women post-menopause. Even before these results, though, based on the perimenopausal status, we may have to rethink the tenofovir, the classic tenofovir use, as there are some data supporting switch to TAF. This study, a small study with 96 weeks follow-up, showed that there is a trend to increase lumbar spine bone mineral density with early switch to TAF in peri and early menopause in women living with HIV, as can be seen here on this diagram, with a black line being the early switch to TAF. Things get more complex when we are talking about the effects of menopause on cognitive ability and mental health. There is a great overlap among menopause symptoms and stress, anxiety, depressive disorders, many confounding lifestyle and medical factors. I'm having here side by side the menopausal rating scale and the screening tool for depression proposed by EACS, and you can see there's a great overlap of symptoms. It is obvious there are no clear thresholds and answers. It is, however, very important to have a discussion with a woman facing challenges and refer them to a specialist if necessary. One major issue with mental health problems is that they may impact treatment adherence and follow-up. In this study from Switzerland, there were increased rates of depression and psychiatric issues when transitioning through menopause. And also, there were some negative treatment outcomes, such as viral bleeds, low-level viremia, viral failure, but all seem to stabilize after the transition. So it is very important for HIV services to be able to support women's mental health during this period. So we know as clinicians that what we need to do for the care of women living with HIV, but how are we performing? What do women think? This is a very recent publication from our group with the results of a survey on women over 50 years old in Europe and their opinion on their care. We got about 600 responses, 72% from Eastern Europe, and the majority were women who had been diagnosed for over 10 years and were on treatment for over 10 years. 75% reported at least one chronic condition, 27% at least three, and not everyone received care for these comorbidities. Most common comorbidities were dyslipidemia, hypertension, and mental health problems, but only about 70% received care for these. Roughly 1 in 2 were menopausal, and half of them had seen somebody, a specialist or a GP, about menopause. Only 24% reported having received HRT for their menopausal symptoms, and about 60% reported satisfaction with the care they received around menopause, but this had geographical variability. When 2 years ago, we asked the healthcare providers this time to tell us how they manage the menopause and the comorbidities, we got answers from providers from 25 different countries. Experienced people, 75% were women. However, 44% were not confident assessing menopausal status and or symptoms, and they asked for more detailed guidelines. They told us that throughout Europe, there are different settings to manage menopause and possible comorbidities, from specialized HIV combined clinics to other specialist services or primary care. What is important is that they seem to follow the proposed screening guidelines for all major comorbidities. But while they often discuss contraception and lifestyle, such as smoking and diet, only 30% has the discussion routinely for sexual well-being with women living with HIV. So the HIV professionals asked for specific guidelines, and in Europe they got them, but the question is whether they can be easily implemented. This is a recent clinical audit report from Sydney, where in a sexual health clinic, women coming in for routine HIV care in the last 2 years recently were assessed, and it seems that in women over 45, 30% had not a recorded menopausal status. Only 15% had a cardiovascular risk score, and none had a fracture risk in their records. So I think this is a warning for all of us to go back and check our daily practice and see what can be improved, because what we answer on surveys and what we actually do in our limited time of 15-minute clinic visit, those two may not always align. Quick mention, when a woman uses menopause hormonal therapy, we always need to check for drug-drug interactions with ART and adjust if needed. Super extra care and attention is needed around oral supplements. This is a very recent journal article stating that the market of menopause products is 17 billion at this moment, and most of that has to do with oral supplements. Nobody knows if they work and what they are doing, but people have been taking them. And maybe, just a thought, a quick questionnaire or an online tool may help have the info around menopause and symptoms before the clinic visit, and will open some topics for discussion. This is a list of menopause essentials in terms of care as published online by EMAs. As menopause affects all possible aspects of a woman's life, no clinician alone can cover everything successfully. It is important to reach out and refer. It is important to collaborate and ideally form multidisciplinary teams in combined clinics. So to conclude, women living with HIV have an earlier and higher burden of menopause-related comorbidities. Cardiovascular disease, mental health, bone health, sexual health are of utmost importance. Are we using different comorbidity screening and treatment algorithms in women living with HIV? Generally, no, with notable exceptions, lipids, and this is a recent change. We do some other things differently, like HPV screening and vaccinations, not related directly to menopause. And women living with HIV who are in care may enter menopause earlier, possibly, but there is a silver lining here, because usually they receive comprehensive care for these comorbidities before menopausal symptoms start. They, however, seem to lag behind in menopause hormone treatment use. And multidisciplinary teams or specialized clinics may be valuable in this context. So thank you very much.